Hi there, it's Justin Lubino again, and today I'd like to discuss with you the latest status on reforming Obamacare. I've spent the last 6 weeks or so trying to get out a updated video and newsletter, and things continue to change, and I just wanted to take a moment here to kind of talk about the current state of things and my perspective on what's going on in Washington as it relates to healthcare. The first thing that I think is interesting, and there's a great video out there that Jimmy Kimmel did, and he did one a few years ago. He did another one just recently. I recommend going to watch this YouTube video. You can search Jimmy Kimmel Affordable Care Act or Obamacare, and it will come up in YouTube. It's a good 3-minute video, and it's just a skit where he goes to the street and they ask people basically which they prefer between the Affordable Care Act and Obamacare. And the responses are pretty amusing. People don't realize that it's actually the same thing. Obamacare is the Affordable Care Act. It's also called PPACA, or Patient Protection and Affordable Care Act. But it's the exact same thing. And the reality is people are just reacting to sound bites that they hear and forming opinions, sometimes strong opinions, without really understanding what they're talking about. So, my first point is, for what I'm going to go through in these slides, is I try to focus on what I believe are nonpartisan sources. I like to use the government.gov site, census.gov, or Congressional Budget Office, or actual laws themselves, so you can look at the actual verbiage in the actual laws to look things up. Kaiser Family Foundation is another good source that seems to be nonpartisan information. So those are good sources. I'm sure there's others out there as well. I recommend steering away from .coms and particular news outlets that may not be nonpartisan in nature. So if we look at the history, in March of 2010, the Affordable Care Act was signed into law. Most people don't realize how massive this law was, but it's over 900 pages. So you can go to look up this law. It's Public Law 111-148, and it's 906 pages of changes to healthcare law. Here's the link as well if you'd like to go check it out for yourself. Additionally, since then, there were 2 other significant laws that were passed related to healthcare. The Medicare Access Chip Reconciliation Act, which was about 100 pages, and then the 21st Century Cures Act, which was just passed this past November, which was another 1,000 pages of law that changed healthcare. So to try and sum all this up in a short 5 or 10 minute video, clearly we're not going to get to the depth. It's going to be just scratching the surface. But I think it's important for people to understand the magnitude of the amount of verbiage that's been changed with the law for healthcare. If we look at the spectrum of ideas that are out there from a political perspective, all the way to the left, you've got Bernie Sanders and the Medicare for All perspective, and next to that you'd have Barack's the Affordable Care Act essentially, and let's skip over Donald for a minute here, but Paul Ryan was really heading up the AHCA and A Better Way. And some of the ideas I'll talk through here are really related to the Affordable Care Act and the AHCA, since this seems to be the most recent potential changes or some things that may get pulled out of here to put into another bill potentially at some point. All the way to the right, you've got the House Freedom Caucus. I know they suggest a full repeal and replacement of Obamacare, not really suggesting how that would be done or what would be replaced with, but that's kind of the perspective of the far right there. Donald, I would put somewhere in the middle, although it's not completely clear. His specifics on the details of what would be proposed, but he has been partially supportive of the AHCA and the changes that were proposed there a few weeks ago. With regards to the healthcare components, there's really 3 components when you look at healthcare at a very high level, right? There's the consumer, there's the insurance layer, and then there's the provider layer. This diagram just shows you the number of people that are covered in each one of these components of insurance. So you've got under private insurance, the employment base, which is the largest population of people, direct purchase, which is people that are buying from, for example, from the exchange, healthcare.gov, and then government coverage. You've got people on Medicaid, Medicare, and military care. The majority of changes that were implemented for the Affordable Care Act are the buckets that are in orange here: the employment-based, direct purchase, and the Medicaid bucket. These numbers, by the way, are from 2015. I know that in 2016 this number went up to about 68 million, but the updated census data is not available yet. The Medicaid number does continue to increase because of the Affordable Care Act. But anyway, the main areas I want to discuss are these three orange boxes. Those are the ones that had the biggest impact with the Affordable Care Act. And I'll work our way up from the bottom there. Medicaid, in the diagram there, the key impacts really was the expansion. And there's a lot more detail to this you can read through in the bill. But at a high level, they basically increased the federal or the Medicaid eligibility from 100% to 138% of federal poverty level. So it added about 16 million additional individuals on Medicaid that would not have otherwise been covered basically by Medicaid without the Affordable Care Act. So, when there's discussions of the uninsured rate and how it's dropped significantly the last few years, the main driver behind that is the Medicaid expansion. With regards to the direct purchase, this is that new marketplace that was created and definitely had some hiccups when it first launched. Over time, though, it has become the tool that people use to buy their individual insurance. There's income-based subsidies that were added with the ACA. So if you're, for example, a family of four under $100,000 income, you get some level of subsidy, and there's different tiers as as the income drops or is lower than that, the subsidy increases with those income-based subsidies. There was also individual mandate penalties that were added with the ACA, which basically said that you have to have health insurance or the government fines you a penalty when you do your taxes the following year. And that's to prevent people from not selecting health and drive more people into the market for health insurance to offset some of the risk with that individual mandate penalty. And then there was the no pre-existing condition exclusion, which seems to be a positive thing that both parties still seem to support, where you can no longer deny people coverage if they had some sort of pre-existing health condition. No more health questions get asked, essentially. With regards to the employment market, let's go down here. The employment-based changes with the ACA, again, this is not a comprehensive list. These are just keeping this video brief. I just want to touch on some of the high-level impacts. One is that the applicable large employers, generally over 50 employees, have to offer affordable health insurance, which essentially means that the employee's contribution can't be more than 10% of their household income. If the plan is affordable and the individual goes and gets a plan on the healthcare exchange and gets a subsidy, they essentially will have to pay that subsidy back because the company offered affordable coverage. The employer shared responsibility, so there was a significant portion of the bill that had to do with new reporting regulations for companies to file these 1094 and 1095 forms, which essentially tracks and shows proof of health insurance for their employees. And this is a very costly and time-consuming process, and there was actually a whole industry built around these forms. Most of the payroll providers that are out there created a service to outsource this and technology to handle all this. Lots of hiccups with that as well when it first launched. But this became very costly and still is time-consuming as well and costly for employers. And then the third piece I want to talk about is the Cadillac tax. And this is one of the main funding mechanisms for the Affordable Care Act. It's basically a 40% excise tax to the employers if they're offering plans with premiums that exceed $10,800 for individuals or $29,500 for a family starting in 2020. Now, this, when it was initially thought of, was sort of a Cadillac plan for health insurance. The reality is especially in New Jersey, where our offices are located. These rates are not Cadillac. These are Kia type plans. If you're looking at the annual premiums, and the majority of plans would actually exceed these amounts by the year 2020. So it's going to affect a large portion of plans and people. And it's not a deductible business expense, so they basically are paying taxes on taxes if they do have to pay that if companies have to pay that Cadillac tax. One of the scary things with the Cadillac tax was the actual projection of revenue that's going to be generated, about $90 billion over a decade was the projection. And unfortunately, about 3/4 of that comes from increased income based on questionable expectation that employers will compensate their employees for cutting their health benefits. So if they're going to cut their health benefits by $10,000 a year, they're going to give that $10,000 to the employee in wages, which the employee will then pay income taxes on. That logic is not reality from my assumption, or our assumption. We just don't believe that's what employers would do if they cut back their health benefits to avoid the Cadillac tax, that they're not going to give that money to the employees as wages. So unfortunately, 3/4 of that $90 billion was projected to come from that assumption or expectation. So when we look at the costs of the ACA, and these are very big numbers, so it's kind of hard to quantify in our heads, but essentially $1.4 trillion is what the latest projection was from 2026. It's over a decade, about $1.4 trillion. So from March of 2015, that number was about $136 billion lower. So that did increase from 2015 to 2016 by about $136 billion. So it's worse, I should say more expensive than originally projected, and the main reason is more people qualified for Medicaid than were originally anticipated. So the expansion of Medicaid drove up the costs further. The other thing people look at with the ACA are the plan choices, and we hear this as one of the main issues with the ACA right now is we're down to about 1 or 2 carrier options in most states. I know, again, where our office is, New Jersey, we dropped from 5 carriers down to 2 carriers. So we're really just left with AmeriHealth and Horizon. And even within those, AmeriHealth has cut their top-level plans. The Platinum and their National Access plans were cut last year. So our choices continue to drop. Premiums continue to go up, and the coverage continues to get reduced. So higher deductibles, higher out-of-pocket costs year after year. One of the main drivers, that no pre-existing conditions situation, results in a lot of people enrolling early in the year, getting their procedures done, and then canceling coverage. And they end up paying a penalty for that, but they're willing to pay the penalty. And then in the future, they would go and enroll again. 2 years down the road, they need another procedure done. They enroll for a couple months and in January and get the procedure done, and then they disenroll. So this drives up claims costs versus the premiums that are being generated, and thus it's not possible for the insurance companies to remain in the market. The other big piece that's in the news lately is the government threatening not to pay the subsidy payments to carriers for the exchange, and this boggles my mind, but there's some folks that believe something about the original deal was not constitutional, and so they're fighting back and trying not to pay out those payments to the insurance companies. This will definitely reduce further the carriers and plans that will provide options in the exchange if they do not pay out the subsidy agreement. So what was proposed was, a few weeks ago, there was this AHCA, American Health Care Act. It was pulled. It wasn't even voted on March 24th. It didn't get the support it needed. The main reason I believe that it wasn't even voted on was the repeal of the Medicaid expansion. The big headlines around that March timeframe was around the 20 or 24 million people that would lose basically coverage by repealing that Medicaid expansion. And I think that was the main driver behind not getting the right support for the bill to get any movement or even get to a vote. But some of the other changes that were proposed in that bill were basically repealing the employer shared responsibility, so that all that reporting on 1095s, 1094s, getting rid of all that, which would go in conjunction with the individual mandate penalty and premium tax credits, basically getting rid of those mandate penalties and reducing the tax credits as well on the direct exchange. I will say the individual mandate penalty was being changed to an enrollment penalty. So if you didn't enroll in coverage and you waited 2 or 3 years and you got sick and you wanted to enroll, they were trying to add a 30% penalty on the premiums. So it's just kind of to me, it's still a penalty. It's still sort of a mandate. It's just how it gets enforced is no longer annually on your taxes, but it's in the future when you go to sign up for healthcare is where you'd be penalized with that 30% increase on your premiums for a period of time. The other piece, the Cadillac tax, was not fully repealed in this bill. It was just kind of pushed out further, which continues to be the case with that. They're not able to repeal it completely because they can't really offset that tax revenue, that $90 billion. They need to find a way to replace in order to completely repeal that Cadillac tax. So some of the other main issues that were in that bill were the funding for federal funding for Planned Parenthood, and repealing of medical device taxes, and the ability to sell across state lines, which doesn't make much sense. As far as a carrier needs to have a network in the particular state to be able to offer coverage, and the costs for the insurance in that state are driven by the providers that are provided in that state. So you're not going to get the same rates, in Tennessee that you will in New Jersey. So, even if a Tennessee provider tries to provide insurance in New Jersey, you still have to pay the insurance company still has to pay the providers in New Jersey that you're going to. So, not sure how that really helps drive costs down. I don't think that's going to be a big benefit. Some of the provisions that are not currently being discussed, in other words, they appear to still have bipartisan support, are the ban on pre-existing condition exclusions and health status underwriting, dependent children able to stay on their parents' plans to age 26. And then this last one are some caps that were put on annual and lifetime limits with the ACA, which is a positive thing. Previously, in certain areas, there were carriers that were allowed to cap an annual limit of $1 million or $100,000, and then the individual would be responsible for any costs above that. The good thing with the caps are there's no longer any individual responsibility over that certain limit, so you can have unlimited coverage at this point. So if I have to come to some conclusions here in a short 15-minute video or so, I would say short term we've got to find a way to stabilize that individual market. That's the short term ticking time bomb that if it isn't addressed soon, we're going to maybe out of options completely in certain markets as the carriers continue to flee. And we've got to, my perspective, the government's got to pay the subsidy they agreed to those carriers, and we've got to find a way to improve the enrollment and cancellation of coverage, so we keep the premiums coming in to offset the claims costs for people that are enrolling and trying to just enroll for a couple months, get the service done, and then disenroll. They've got to address that piece to keep the carriers in that market. Long term, this Cadillac tax has got to find a solution to get rid of completely, or else it's going to impact everyone on these employer plans, and they'll have to keep cutting back employer coverage, maybe get rid of it completely, which I don't think is a good thing. And then the reduction of back-end costs. This is something that is not getting a lot of attention. Unfortunately, it's that middle layer in the diagram that seems to be getting the most attention, the insurance layer, where the back-end piece, the pharmaceutical and the medical costs are the drivers. The insurance is just a financial vehicle that sits on top of those back-end costs. So I think this is an area we've got to focus on, in addition to insurance, to drive the costs down going forward. So, and then lastly, I recommend doing your own research, make your own conclusions. So it's very important. This is a 15-minute video. You might get some sound bites from it. Hopefully I sparked some interest, but if you're going to make and if you're going to have an opinion on this topic, I do recommend look into the right sources and not just sound bites from different news networks. So I hope you enjoyed this video, and if you have questions, you've got my phone number there. You can like us on Facebook for additional updates, subscribe to us on YouTube going forward, and I hope you have a great day. Thanks.